fluid from the cavity of the eye gets underneath the hole, and like wallpaper peeling off a wall, the retina lifts off, and it's a detached retina. Now the whole eye is being filled with an air bubble. It's called an air-fluid exchange. We basically suck out all the fluid and replace it with air. So the entire cavity of the eye is filled with a gas bubble, just temporarily, but so as to push on the retina and allow the area with the laser to form a tight seal so that that torn, damaged area will scar down and not cause a detachment. And then the body just absorbs the gas over a few weeks, and it just replaces it with salt solution. So the vitreous never gets reproduced, but you don't need it. It's interesting. The vitreous is a substance that just is part of the embryologic development of the eye. But once the eye has developed, once we're born, it actually has no function. In fact, the vitreous is the cause of most retinal troubles. The vitreous is what pulls on the retina, creates tears, causes retinal detachment. The vitreous is what pulls on abnormal blood vessels in diabetes, tears them and causes bleeding and traction in diabetes. So if we could be without vitreous, we'd all be in a lot of ways better off. But unfortunately, that can't be, so we have to deal with the problems that it causes. This is someone who had a cataract operation, and what happened is instead of all the cataract coming out, some of it fell into the eye. So the cornea is cloudy, so we have to take off some of the cloudy parts. Now with this little vitrectomy cutter, we're starting to cut out some of these fragments of lens that are floating around in the eye. You see these white sort of particles throughout, and in a minute when we turn the microscope on, you can see there's big chunks of cataract inside in the back. There's a big piece there that's being taken out, but it's floating around in the eye. It's interesting, the reason you can't just leave these pieces in someone's eye. If a cataract operation is done and these pieces fall in, the body interprets them as foreign bodies, as foreign materials, and this really dramatic inflammatory response happens. And the reason is because a cataract means that your natural lens has gotten cloudy. But the natural lens is like an onion. It's basically got a capsule or a shell all the way around it. And the contents of the lens are something that the rest of the body is never exposed to. Suddenly, though, when a cataract operation is done, what the cataract surgeon does is he opens the front of that capsule and cleans out everything inside the lens and then puts in a plastic artificial lens. But if the cataract operation has a complication and that capsule breaks, then suddenly the internal contents of the cataract fall into the eye, and the body interprets that as a foreign protein, and that's why it creates this very dramatic inflammatory response. The pressure goes up, the eye gets incredibly red and irritated, and that's why we have to remove these pieces. You just can't leave it. That being said, with the techniques that we have now, it works very well. But as a retinal surgeon, I think when I'm advising people about cataract surgery, I'm much more cautious than a cataract surgeon, because from a cataract surgeon's point of view, 99% of cataract operations go great, and the patients are happy, and it's the greatest thing. From my point of view, I only see the patients who have complications from cataract surgery, so I have a completely different view on whether someone should have an operation or not. So I tend to dissuade most patients from cataract surgery often. Switching topics a little bit, we've had amazing developments in terms of technology that allows us to investigate retinal disease in the last few years. And now for about the last 4 or 5 years, we have what's called Ocular Coherence tomography. And what it does is it allows us with exquisite detail to see the structures of the retina and the center of the retina called the macula in ways that we never could see before. And this is the instrument. Actually, this is already outdated. Just last week, through the help of the foundation, we have a newer version of this machine, which actually shows even more details than this. This machine's about 5 years old. The new one, which hasn't been hooked up yet here, will greatly even enhance what we can do. But this is a picture of the normal retina, and this is normal. This little dip is called the fovea. It's the center of the macula. It's the area where one gets normally adherent to the retina, but what's happened in this case, it's very adherent. The vitreous has started to pull, and like a tent, it's lifted the whole retina up. So not surprisingly, a patient like this can't see any details. The amazing thing is, as obvious as this is on this OCT picture, when you look at them with the conventional techniques that we have to examine patients, it's often almost impossible to detect this. And in the past, before we had OCT available, a patient might come in complaining that their vision's down, and the surgeon will look and really not know what the explanation is. Other photographic techniques wouldn't show this at all. So that's how dramatic this is. It not only, in a situation like this, allows us immediately to know what's going on, but it immediately allows us to know what to do about it. And then what we do about it is we do a vitrectomy and peel this vitreous adherence off, which allows this retina to fall back, and their vision is restored, and the whole problem is solved. That's the other thing that's so nice about retinal surgery, and one of the things I think that led me into it is a lot of what we do definitively repairs these conditions. We're not just sort of putting off future problems or giving patients a little bit more time. We can solve these problems in most cases definitively with one procedure, which is really amazing. Macular hole is another condition which 10 years ago we recognized, but we didn't know we could do anything about it. This is a photograph of macular hole. This is the retina, and there's a hole in the retina right smack dab in the middle. And this is the corresponding ocular coherence tomogram showing a hole right there in the center of the retina. Up until a few years ago, it was thought that there was nothing to do for this condition. It was thought that it was a hole, that there was a piece of tissue missing, but there was no treatment available because we didn't think there was a way to, put back tissue that was missing. But a couple of smart retinal surgeons in Sacramento, California actually realized that in the majority of these conditions, there's actually no tissue missing at all. It's just due to traction. It's like my coat coming apart, that it's just being pulled apart. There's actually no tissue missing. It's just being yanked apart, and that's what's creating the hole. So if surgically we can relieve this traction, those edges will come back together, and the hole, for all intents and purposes, goes away, and in the vast majority of people, vision is restored. And that's surgery now that we do routinely with over 90% success rate. So, and we'll see some more examples of that. But the following is a list of really major advances we've had in retinal surgery, all really within the last 10 years. Macular hole surgery, which we'll talk about. Subfoveal surgery, meaning we actually operate underneath the retina to resolve problems. We've got much better viewing systems, wide field viewing systems that allow us to see details that we could never see before surgically. We use a class of liquids called perfluorocarbon liquids that are heavier than water, which allow us to repair conditions which we couldn't repair. In the last year and a half now, we have 25 gauge vitrectomy, which I'll show some video in a moment of that. But the conventional vitrectomy for the last 20 years has been with 20 gauge instruments. 20 gauge is a measure of the thickness of those things that we're sticking in. 25 gauge is less than half as big. And the reason that's been a huge advance is it not only speeds up the surgery, but most importantly for the patients, no sutures are required. So it's infinitely more comfortable